thanks to all of you attending this meeting, and especially the board that was already mentioned. I'm very proud to be sharing the introduction to the Healthy Hearing Ears initiative with you on behalf of all the people attending here. I'm waiting for, yes. So to start with, hearing loss is, as you all know, one of the leading causes of disability worldwide, occurring in 460 million of people, which is 6% of the total population. Hearing loss substantially alters people's life, resulting in, but not limited to, communication difficulties, social isolation, depression, falls, and increased healthcare use. And as this slide shows, you can see there is a regional spread in the burden, but it still accounts for 50% of the CSOM population. Another important thing to share with you is the fact that the surgical treatments for COM-related hearing loss are, although we really aim for creating also a good hearing, the hearing loss is less successfully treated than the control of the infection. Many patients, therefore, have long-standing hearing loss before getting a solution. And we believe it's important to acquire a global consensus for the treatment. When we started this initiative, we have been looking into the literature to start with, and we were aware of the fact that there were only 31 studies running on COM. Compared to, for instance, 232 studies on tinnitus, this is a large difference. And we feel if you look into the numbers of studies collecting hearing outcomes, it's only 5, and that studies evaluating hearing treatment, only 2, there is a large to gain. In this initiative, we have been, let me see if I can go to the next slide. Sometimes a little bit slow, I'm sorry for that. Let me see. Yes. So, oh, no, it's too fast, of course. That was the risk of my action. I'm sorry for that. So the aim of this initiative is to gather consensus and to create more awareness. And the advisory board is listed again in this slide. They have been introduced to you by my colleague, Dr. Kaplan, already. And I will continue with what this initiative is about. Yeah, there is keeping some problems with me going to the next slide. I'm sorry for that. I'm not sure what, maybe somebody can take over my, yes. So what is important? We have been evaluating 3 important things. And of course, this is important to state here that you would like to see patients having a care-free, dry and hearing ear. So one of the important aspects of this initiative is to make sure that if there is a patient with no hearing, a lot of issues to take care of, and the ear is not dry, it's important to refer and to make sure that the patient gets access to adequate health care. In the discussion paper that we have been signing up together, we have been seeing that there is a lot to gain. I've been talking to you already about the hearing outcomes that is suboptimal, and we see that there is a lack of global consensus. So what we believe is that this discussion paper is helping in getting more awareness for these patients. The literature review that we have been performing is listed here. It's a lot of data on this slide. I think the main important thing to remember is that if we look into this literature, these 31 papers, that the complication rate is about 14%, mainly accounting for tympanic perforations. And another important aspect is the number of patients that are still having an air-bone gap of larger than 20 decibels. And we believe this amount is too high, and we need to make sure together to have these patients get access to better hearing in an earlier stage. This is a slide I would like to share with you, although it's also a little bit difficult slide. But the thing is that in Sweden, they have been having access to a national registry, which I think is very important in order to get qualitative and good data about especially this disease and the care that has been given to the patients. You can see that not only before and during treatment, but also after treatment, there still is costs involved in this specific patient group. And this is an important aspect of the consensus that we believe there should be prepared. To start with, increasing the awareness. Hearing loss is an important aspect to cover. And the thing is that what I wanted to mention is the UK survey. I'm sorry for that. And in this survey, it was known and shown that there is less awareness. And especially if you look into the data of the audiologists, we saw that only about 26% of the audiologists were aware of the fact that a bone conduction device in a long-standing COM with conductive hearing loss might be a good alternative. And a lot of patients, more than 60%, have, due to the recurrent infections, a long-standing hearing loss of more than 11 years. So the steps we would like to take with this initiative is also to start the clinical research. The study is shown into this slide. I will click a little bit further so you can see what we are aiming for. We like to include patients with COM and an air bone gap of larger than 30 decibels with a tympanoplasty in the history and the trial of a hearing aid. And we would like to perform not only medical chart review to see how the current statement of treatments is, but also include patients in a randomized controlled trial with either hearing aid or bone conduction solution to see and continue to watch how they develop and how their complaints progress over time. And of course, if we can reach adequate hearing sooner than registered in the literature. You are able to participate in this initiative. If you would like, you can send an email to the email address listed below. Another important thing I would like to share with you is the fact that we not only would like to measure the decibels, but also the quality of life, which is an important aspect of current scientific literature. And I feel it's important that not only the surgical outcomes, but also the quality of life outcomes related to the cost are measured. And we have chosen to use this COMBI 15 question counting questionnaire for this, which is short, easy, and very valuable to use in this patient group. So to summarize this introduction, the COM-related hearing loss has a big impact on healthcare use in general, in numbers of patient visits, in cost, but also in quality of life. And patients with more severe middle ear problems often struggle several years, sometimes even 11 years, to find a good hearing solution. The quality of life and also the working life is greatly influenced by this. We believe that it's important that with this initiative, we really hope to create awareness whilst improving patient outcomes and shortening the time to get a good hearing outcome for all these patients. And we know it's an ambitious mission statement, but we believe that we can be strong together. Thank you.
Thank you, Dr. Hall. That's a great presentation. And I think it really outlines that the world is changing when it comes to these interventions, and the health economics is going to be playing an increasingly large role, as does the patient outcomes, the self-reported outcomes, the quality of life metrics, where it's more than just the pure clinical data that we have to collect to be able to move forward. So I think it's really important to bring that to everyone's attention. Thank you very much. So next up, we're going to have Professor Thakkar.
I just need to inform we have not managed to get Alok online, so we need to skip
for
now
fine.
and run to the next presentation, which is Raphael, I believe.
Yep, you got it. So we'll rearrange the order slightly from the from the presentation you showed. Dr. Rafael Yamarillo is an otologist based at SES Hospital in Caldas, Colombia. He has published many papers in the field of bone conduction and is particularly interested in the clinical benefits of bilateral implantation. He's going to be talking to us today about blind sac closure, when and how. So welcome, Dr. Yamarillo.
Thank you, Brian. It's an honor to be part of this group. My name is Rafael Jaramillo. I am an otologist and a school-based surgeon. I have problems to pass my presentation. Could you help me? The next slide. Okay, thank you. My name is Rafael Jaramillo. I am an otologist and a school-based surgeon in this beautiful city, Manizales, Colombia, South America. Next slide. Today, I'm going to talk about when and how to perform a blind sac closure or a subtotal petrosectomy. I did a review and I found a few journals talking about blind sac closure. The indications are chronic otitis media, cholesteatoma, tumors, meningoencephalocelic, leaks, and cochlear implant in difficult situations such as temporal fracture, ossification, or inner ear malformation. Next. The main indication is in the management of chronic otitis media refractory to surgical treatment in patients with severe to profound hearing loss. Next. This is probably the biggest series from Dr. Sana, with 460 patients, where 64% had multiple surgeries, 35% recurrent otitis, 90% difficult cases of cochlear implant, 30% meningoencephalocelic, and also temporal fracture and tumors. Next. In the last decade, blind closure has become the gold standard of in deaf patients previous to cochlear implant, even simultaneous or sequential. Both papers show that cone was the main indication, as we can see in this slide. Next. Subtotal petrosectomy was also used in association with viriloplastic surgery in patients with pure sensorineural or mixed hearing loss. Most of the patients show decrease in bone threshold after surgery in this paper. Next. Patients with chronic otitis media have been shown to have lower levels of quality of life, social functioning, and perception of general and mental health than non-affected subjects. Next. As you can see, in most of the cases, subtotal petrosectomy is performed in patients with no good hearing. In this paper, 86% of the patients have a bone threshold under 90 decibels. Next. I would like to show you 8 patients with COM and BAHA, all of them with a normal bone conduction hearing. In 2 of them, I couldn't make a blind sac closure. Next. The third one, because infiltration of the facial nerve. So I leave the open cavity. We can see the third portion of the facial nerve. The patient has preserved the facial mobility. We can see here the facial nerve. This one is the third portion. This is the lateral canal. Next. Next slide, please. Thank you. And the second also for infiltration of the posterior dura and the sigmoid sinus. that I couldn't remove too. Here we can see it's a soft tissue, and there is the posterior dura and the sigmoid sinus. Next. In the other 6 patients, I performed a petrosectomy, and 6 months later, a second look with BAHA. All of them were free of cholesteatoma, one minor complication, a wound infection. I do some modification to the classic technique. First, I close the external canal in the lateral portion. We can see in this photo. It was a few days ago. Look at the mask of the patient. It's a COVID photo. Next. And second, I do not make a complete exsanteration of all pneumatic tracts. I perform a wall-down mastoidectomy, removing just the diseased tissue, like on demand mastoidectomy, leaving the Eustachian tube open. You can see here the Eustachian tube. And with no obliteration of the middle ear, no any graft in the cavity. So it's safe, fast, and with great results. Look at the video, it's a small cavity. Here we can see the stapes, the Eustachian tube, the promontorium, the lateral canal, and no any graft in the cavity. And also we can see here a CT scan 6 months after the blind side closure, and we can see it's a great cavity. Next. One before. Okay, thank you. As a conclusion, I want to leave you a question, and it's why not to perform a blind side closure and a conduction implant as a first choice in those patients in which we know hearing rehabilitation has a few possibilities. Thank you very much.
Thank you, Amerigo. That was a great presentation. I think that's an intervention which probably does not get as much attention as it should when you look at how successful it is frequently in eradicating disease, removing the symptoms, and improving quality of life as well for the patients. So it's great to bring that up today on the discussions. Thanks again. So next up, we're going to have Dr. Lederartz, is the director of the German Hearing Center and the Research Institute of Audio and Neurotechnology in Hanover, Germany. His research interests are in auditory implants, biomaterials for medical implants, audiology, and neurotology. And he'll be talking today on prognostic tools and outcomes with bone conduction and chronic otitis media. So welcome, Dr. Lederartz.
Now, thank you much for the invitation to be part of this panel of distinguished specialists in the field. My contribution is on indication criteria derived from clinical data we have got from our patients using bone anchored hearing aids. And that's just what I want to share with you. The work has been compiled mainly by Susan Busch, who is working as an audiologist at our department and follows those patients. Now, BAHA indications criteria by manufacturers, you can see here. That's for the BAHA Connect, which means bone conduction threshold over 4 frequencies equal or less than 65 dB HL. And the BAHA Attract has 10 dB less effectivity due to the skin between the magnet and the outer magnet. Now that means that you probably can serve patients with conductive or mixed hearing loss with an air bone gap of greater than 30 dB, or for single-sided deaf patients with cross the bone conduction on the better side should be equal or better than 20 dB HL. That's just what the manufacturer indicates. Now, when we look on the current available products, then we can see that there was an improvement done by the present speech processors, which have become more powerful than the former ones. And when we look on the 3 classes, BAHA 5, BAHA 5 Power and BAHA 5 Super Power, then probably we can see that given the indication criteria for a manufacturer, it basically would go down to this threshold for bone conduction in the patients. And that is approximately 5 to 15 dB less for the BAHA Attract. Okay, now looking on the literature, we can see that there is an MPO that has been defined in this study by Carlson, Håkansson, and Swartenkort, that with the standard BAHA BP100, basically MPO is something like 67 to 69 dB HL, and that is from the other products, the standard Ponto is the same. Now, when we look on the BAHA Cordell of the Superpower, then the MPO goes up to 80 to 85 dB HL, and there is probably the same found here by this literature studies. So now going one further, okay, I hope we can advance it. So this is not following. Yeah, okay. Now that means if you go for this kind of MPO and we take the dynamic range of 35 dB, which is necessary to display the speech signals, the dynamic range of a speech signal to the patient, that with this given MPO, we probably would go to a maximum hearing loss reflected by bone conduction to something like, sorry, I was too fast with the pressing. I have to go back. Sorry, I have to wait. I was impatient, yeah. Okay, so that means that we probably can serve patients up to 32, 34 dB HL. And with the Superpower, this goes up to 45 to 50 dB HL. So it's basically that's what we can derive from the MPO and also the references that have been put out by literature itself. Looking on our own patients, these are 58 subjects using the Connect. We see the following. That is just the monosyllable word score going from 0 to 100. And that is what the single patients get. Each is a symbol for one single patient. And what we also see is that we have patients who use the older processors, that is a round symbol. And then we have patients that use the newer processor, which is a triangle. And we can clearly see that patients with the older processor start to go down with their monosyllable word scores already with the bone conduction threshold of approximately something like 35 decibels. So let's see, let's cut this line here. Now, what is our criterion to say that the patient is served well with this kind of bone conduction device? Well, we arbitrarily just choose 60 dB monosyllable word score, because that is something that is a score where the patient is able to follow conversation and probably also can use the telephone. So 60 dB, if you cut this line over here, you see that those patients who are below it are basically here. And with the increase in the bone conduction threshold, you get more patients who are under this line. And we see that with the newer processors, there are more patients up here which have a loss that is above 40 decibels. So just go for the next. Wait a bit until that is displayed. Oh yeah, okay. So now looking on this diagram, this is the 60% monosyllable word score line. And then you can see with the standard 45 that probably we have here one patient with a newer device, which is here below this 60%. Here we had older devices where already we have at something like 35 dB patients out of this line. Okay, now here you see the indication limit given by the manufacturer, and you see that if we take this indication limit, then probably most of our data we have got are, so to say, on this side. Only a few patients here are on this side. Looking on the Power 55, so you see again, there's only one patient below that line. That is a given indication criterion by the manufacturer. And we look on the Superpower, then we can see that we have a few patients with older and newer devices, which are probably if you would follow this line of the manufacturer's indication, we're probably below the 60%. So that means, derived from that, we, from our clinical data, would put the line up to which a patient can be predictably served well up to here, so something like 50 decibel. And so, okay. Now that is again for the Baha Connect. These are patients, former versus new one. 10 of them are bilateral served, and you see if you just look here on the range, that patients with the older devices probably have a wide range of results compared to patients with the newer ones, where we have more narrow distribution, which of course is also important to look at. So you see, I mean, probably if we take the line at 50 dB hearing loss, then probably most of our patients are, so to say, on the safe side, having more than 60% motor silver Wert score. Okay, now let's go on with the Baha Attract. We have only a small group of patients. Probably they have little hearing loss, as you can see here. So there's one patient who is not satisfied. So we try to bring him up with a new, more powerful processor, and this worked quite well in that patient. Now, looking on our single-sided deafness population, it's important that the contralateral ear is still in a good condition, so that the stimulation across the head still can stimulate the better ear in sufficient way. And again, when we look here, that is basically the indication limit that was initially given by the manufacturer. We see that probably most of our patients are here on this side. Sorry, but still there are many who still could be served even with higher levels of hearing loss on the contralateral ear. So that means we have enlarged indications with Superpower processor up to 30 dB and plus dB HL on the contralateral side, which means that we have a wider range of indication with this kind of powerful processors compared to the former situation. And summarizing it, we would say the Baha Connect, we see improved results with new speech processors. Above 30 dB HL, the results are spread. Up to 50 dB speech recognition or over 50 dB speech recognition basically drops below 60%, and therefore we would give a clinical indication limit of 50 dB HL in our practice. The Baha Attract, I think 5 to 15 dB loss due to damping means that if we subtract it from here, then we would say limitation is given by 40 dB. And looking on single-sided deafness, we see that with the Superpower we can widen the indication, and there are patients who have a loss up to 30 dB on the contralateral side can be, so to say, served in a safe way, which I think shows the potential of the bone-anchored hearing aids, which we could give to the patients with either pure conductive or mixed hearing loss. That's just what we have got from our patients. Thank you for your attention.
Thank you, Dr. Lennartz. That was great. And we have a few follow-up questions that have already been entered in chat regarding some of these clinical indications. I think we'll circle back at the end when we open it up. But it's always great to see the clinical data overlaid with real patients. So much appreciated. So the internet gods have allowed Dr. Thakkar to tune in from India, so we're going to go back into the order there. We're glad that he was able to join us. Dr. Thakkar is Professor of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences in New Delhi. Dr. Thakkar has a special interest in head and neck oncology and the entire spectrum of skull-based surgery. We're discussing today why do mastoidectomies fail and lessons from the past. Dr. Thakkar.
Right, good evening and good day to all of you out there. I'm sorry for all the internet issues that are popping up every now and then. So this is about mastoidectomy and ear discharge. So I know that that when we do ear surgery, we're a little bit more likely to work to succeed with sorting ear discharge and with sorting hearing, but nevertheless, this itself can be a bit of a problem. So moving on to the next slide. Oh God. Yeah. So what is cholesteatoma? Cholesteatoma, and the simplest definition that exists out there, basically says that cholesteatoma is a pocket of keratinized squamous epithelium, which is filled with keratinous debris. Of course, it's also bone eroding, and of course, there's inflammation associated, and it secretes cytokines and all those kinds of things. But the simplest definition out of there, which is sufficient, is to say that this is a keratinized squamous epithelium lined pocket, which is filled with keratin debris. And what I'm going to try and say is as to why it happens and what we can do to treat it with the best results that we can have out there. Next, please. So we basically treat it either by exteriorizing the pocket, which is when you do a canal wall down mastectomy, so that you still have a pocket but no keratin debris inside it. That essentially is a canal wall down mastectomy. In the next slide. So the other thing that happens out there is that sometimes you ventilate it, and that is a canal wall up mastectomy. So why it fails? Number one is pathology. It fails because of pathology. Next. So can I ask that you just keep moving the slides regularly? So there are two kinds of pathologies for cholesteatoma: cholesteatoma by retraction and cholesteatoma by invasion. So cholesteatoma by retraction is the usual cholesteatoma that we see, which is this, what you see out here, which what you see is that there's been negative pressure in the middle ear and the attic, and of course the tympanic membrane and the pars flaccida is pulled inside, and then there is collected debris. But the invasion one is the more difficult one, which is rarely something we see nowadays. I used to see it when we started out 30 odd years ago, but even then it was very unusual. So this is a situation where you get an acute necrotizing otitis media, something we see very rarely today. But when you get acute necrotizing otitis media, the whole tympanic membrane sloughs off, often with the annulus, and this heals primarily by the migration of epithelium or the external auditory canal into the middle ear. This is very different from a retraction pocket cholesteatoma because this is very thin epithelium. There's no underlying subepithelium tissue, very tightly adherent to bone. Sometimes osteitis under it, and you can't quite excise this cholesteatoma. So when you have this kind of cholesteatoma, you are likely to have far more likely issues of recurrence out there. So may I move on to the next slide, please? The next reason we fail, of course, is physiology. This is really important. So here I'll restrict myself to the cholesteatoma by retraction, which is the one that we really see nowadays. The cholesteatoma by invasion that I talked to you about is very unusual. If you see it, you need to have a different philosophy on how to treat it. And basically, you need to look at a canal wall down, modified radical or radical mastectomy. A tympanoplasty is a difficult situation in that situation. Cholesteatoma by retraction that you tend to see is a cholesteatoma which occurs because of negative pressure in the middle ear or the attic. If there is negative pressure in the eustachian tube, you'll probably get a posterior superior canal cholesteatoma as you see out there. So posterior superior retraction cholesteatoma as you see out here, which is, if you have a cholesteatoma, which is, next slide, which is because of, sometimes what you can have is that the diaphragm which separates the attic from the middle ear, which is the mucosal diaphragm, that gets obliterated. The small isthmi which cause ventilation of the attic through it get obliterated, and when that happens, then you can have good ventilation in the middle ear that you see now, but poor ventilation in the attic, and then you'll get the isolated attic cholesteatoma. Next, please. Of course, there would be occasions wherein you would find that both may occur, because when there's a posterior superior retraction cholestoma, it may itself go on to cause obliteration of the isthmi in the diaphragm separating the attic and the middle ear, and so you get both, which is what you see here. So as we move on, assessment of next slide, assessment of ventilation is really the most important thing to do, because if someone has good ventilation, then you can really do option number 2, what you see out there, which is that you excise the pocket, reventilate the middle ear through the eustachian tube, and if you reventilate the middle ear, you can have normal anatomy, better hearing, and a canal wall up mastoidectomy or a combined approach tympanoplasty. If you have poor ventilation, then you obviously don't quite succeed by trying to ventilate the ear with a canal wall up mastoidectomy, and then you have to go down to the option of exteriorizing the pathology, which basically means a canal wall down mastoidectomy and the large cavity, which you may obliterate. So exteriorizing the pocket becomes. So how do you assess ventilation? This is a multifactorial thing. Next, please. So the assessment of ventilation is multifactorial. It of course depends on whether the patient can do a Valsalva or a tympanometry, what you see out there. But there is more to it, because you need to look at the nasopharynx, see if there's any pathology in the nasopharynx, if there is a cleft palate or a submucous cleft palate. You need to look at the extent of cholestoma, and you need to look at the cellularity of the mastoid. And putting these 3-4 things together, the look of the nasopharynx and the palate, the look of the mastoid cellularity, and the extent of cholestoma, do you get an assessment of the ventilation, combined of course with Valsalva and tympanometry. So next slide, please. So what you see here is 4 different grades. On the first side, you see in the left here that the attic cholestoma is there, but nothing in the middle ear. Of course, eustachian tube function is good here. It's only a problem in the diaphragm, which is not allowing ventilation from the middle ear to the attic. Number 2, you see that there is an issue with posterior superior retraction pocket, and so there is obviously some issue with ventilation on the eustachian tube. Number 3 is a bit worse, and number 4 is of course much worse. So just an assessment of the degree of retraction and the degree of cholestoma, the extent of cholestoma gives you a hint as to how bad the ventilation may be at this moment in time. And next, please. If you look at the cellularity of the mastoid, then again you can see that in the first slide there's some cellularity, next time there's sclerotic, and then there's a cavity. So the worse it is in terms of pneumatization, you again have an assessment of how bad the ventilation is. So you put this all together. Of course, if you have option 4 on what you see on the middle ear and a cavity as you see on this, it would not be appropriate to consider a combined approach tympanoplasty in my practice, at least, because you know ventilation is very poor, and ventilation is poor, then to hope that this thing can work by re-establishing ventilation might not be such a great idea. So next, please. So lastly, we come to anatomy. So we talked about pathology, we talked about physiology, which was basically ventilation, and then we talk about anatomy. So anatomy is important because attic cholestemas and posterior superior retraction cholestemas behave differently. Next, please. So when you have an attic cholestoma invariably moves lateral to the ossicles. It's always going to be lateral to the head of malleus and the lateral to the short process of malleus. And next, please. And the posterior superior retraction cholestoma is going to be medial to the ossicles, always will be. So it will go down, it will go deep to the short process of short process of incus, and naturally it's very difficult to excise this cholestoma unless you also remove the ossicles in the attic. And to my mind, removing of the ossicles in the attic is the key to getting good excision in a lot of these patients, especially with posterior superior retraction cholestemas. So next, please. So we'll just see this small video, which is basically showing a patient with a posterior superior retraction pocket, also a bit of an attic retraction, so a little bit of both. And what we're trying to do here is, of course, excise the retraction pocket and then reconstruct in a canal wall up way. But even if you want to do that, you have to be careful that if you excise the cholestoma, you have to make sure you get at it all. So as you say, you raise a flap, and when you raise the flap, you can see that you can raise it easily because there's a retraction cholestoma. There is still some mucosa on the middle ear. You can easily elevate it off. And now you see the stapes and the facial nerve, but you find that you can't excise more because the cholestoma is going medial to the ossicle. It is going medial to the incus. And you can't quite excise more unless you would sort of take off the ossicles. So now we drill a little bit, get access to the attic. And even as you look at the cholestoma in the attic, you'll find that there's very thin epithelium in the attic. You can see the so-called buttocks of the head of malleus and the incus, and you see that this flimsy epithelium on it is not easy to get off the ossicles. So the safest way, even for the flimsy epithelium in the attic, and more so for the cholestoma going under the ossicles, which is the posterior superior pocket, is to remove these ossicles in the attic. And only when you do that, at least in my practice, can you have the confidence that you have removed this well enough to be able to then reconstruct. So now you see that now that you remove the ossicles, you're confident, you put in a cartilage to reconstruct the attic, and you put in a graft, and you're done. May I have the next slide, please? So excision of attic ossicles is key, especially for posterior superior retraction cholestemas, which will go under the ossicles. You don't necessarily have to do it for attic cholestemas, but certainly for posterior superior retraction cholestemas. So now the last couple of slides. So why mastectomy fails? This was a key slide given to me when I was a young trainee, which was that there are potential residual sites both in the anterior tympanic segment and in the posterior mastoid segment. So in the anterior tympanic segment, you basically have to go around like a clock, and at 1 o'clock you see the anterior epitympanic recess, which you always have to look for because there might be some residual disease there. Of course, the peritubal cells below it, the hypotympanum if the disease is going there, posteriorly the facial recess and the sinus tympani, and superiorly, as I say, under the attic ossicles. So you need to go all around and just make sure that there is no disease out there. In the mastoid segment, similarly, you can have disease anteriorly in the retrofacial cells if it's a cellular mastoid, or in the tip, or in the sinodural angle posteriorly, or sometimes it's the perilabyrinthine cells if it's a very cellular mastoid. You can have issues if there's graft failure. You can have issues if there's inappropriate ventilation. I talked about it. All of this will occur in the middle ear. And if you're doing the canal wall down, then you will have issues with inappropriate lowering of the facial ridge. They should be lowered at least till the annulus, and if necessary, maybe even till the facial, the vertical facial canal. And of course, an appropriate meatoplasty. If you're doing a large cavity canal wall down, then you might need to do a good meatoplasty. So you put this all together. This is the key slide. You put this all together, and you're unlikely to have significant recurrences. Sometimes you will have these other issues which are very rare. So if you look at a book, you will have these other issues which are very rare. In my own practice, I've hardly ever seen them, maybe 10 to 15 times in my career. But the next slide, which really is again the same slide we saw the last time, is the key. So this is something, this is the take home message on this one. This is key. Next, please. So if you leave behind disease, then you will get a residual. And I just told you what are the size you leave behind. And next, please. If you're doing a canal wall up and you have inappropriate ventilation or your graft failure, of course, you'll get a recurrence of discharge, not necessarily a cholestoma appropriate. And if you're doing a canal wall down, you will get recurrences if you do not appropriately lower the facial ridge or do not do an appropriate meatoplasty. So that is it. Thank you.
Thank you, Dr. Thakur. One quick question. I was looking for a great review of the pathophysiology leading to this. I'd be curious your thoughts on the eustachian tube balloon and other methods of attempting to dilate the eustachian tube and improve that function long-term in your treatment for these poor ventilation ears.
I think it has a potential to be a game changer, but it's early days yet, and we sort of don't quite know if it's working or not working. I mean, certainly the key to middle ear disease is going to be improving eustachian tube function. Whether this modality itself will work enough or not, whether you can actually just make a single dilatation for a few minutes and expect that that would sort out the pathology which is going on for years, I'm not that sure. So certainly it's something to look at, but whether it will work, I'm not so sure. Thank you.
Great. Thank you very much. Wonderful talk. So next up will be Professor Jay Desbray. He's a consultant ENT surgeon at Sheffield Teaching Hospital and professor of otology and neurotology at the University of Sheffield in the UK. His main research interests include complex hearing loss and implantable hearing solutions and management of balance disorders. And he'll be talking to us today about outcomes with the osseous system in chronic otitis media. So welcome.
Thank you for the nice introduction, and thank you for this opportunity to share our experience with the osseous system in chronic otitis media, which actually comes in quite nicely following Alok's talk and previously from Professor Lenaz's talk as well. Next slide, please. Great. too fast, going back. So I'll just take you through a quick background before I launch into the product itself, which we have had experience of. I'll take you back 4 years, way behind, in a different world before the pandemic, when life was much easier to meet face to face. The British group met up with the Dutch group, and we looked at developing a consensus on managing chronic otitis media. This was 2016, a very nice meeting, and we came out with a consensus document with the conclusion that there doesn't exist much of a consensus. And the reason for that was patients were looking as if they were being stuck in a vicious cycle of discharge, hearing aids infection, surgery, the hearing aids infection, discharge, and not coming out of that cycle. We surveyed about 116 patients in the UK and looked at their experiences. A huge number had significant morbidity. Many had waited several years before the actual problem had been sorted, and they were going from clinic to clinic. However, many of them had benefited from alternatives to air conduction, i.e. bone conduction. Hence, we wanted to look at a little bit into the option of bone conduction in patients who struggled with COM and air conduction hearing aid related infections. So, looking at the literature, there's a significant burden of disease globally, and their patients do suffer from a huge amount of hearing loss in this situation. And the impact is on communication, education, employment, recreation, dementia, anxiety, depression, etc., etc. The link between unresolved hearing loss and early onset of dementia is well proven now. Many of these patients, as we've heard earlier on, end up with multiple middle-ear tympanomastoid surgery. Whilst air conduction remains the mainstay of treatment and standard of care for them, they may not be useful or appropriate for some of them, and hence the huge morbidity, as I've alluded to earlier. Looking at our survey, many of them are elderly. Many of them have bilateral hearing aids, both of which may be out of use because of infections. As a result, they end up with huge amount of social isolation, and it is obvious from this, the social isolation is higher in the older age group. Many of the patients are unaware of alternatives available to them, and there is very little support from other sources because of the lack of awareness. Whilst this lack of awareness exists in outside, there has been a silent revolution in the acoustic implant world. And we've heard in Professor Lenaz's talk about the various options there are in bone conduction technology, which come under the umbrella terms of, percutaneous and transcutaneous implants, active and passive devices. And I won't go into the details of this, but I'm sure majority of you would be aware of this. I won't preach to the converted. Percutaneous devices, again, produce a very good result, as you've already heard, and they remain the backbone of bone conduction and acoustic implant technology. However, there are several issues with them, and that's linked to the skin penetrating nature of these devices. And they're linked to soft tissue issues, the fixture abutment, stability, the interface between the soft tissue and the abutment, the lateral projection, cosmesis, amplification, etc., etc., etc. The transcutaneous devices, as they evolved about 9 years or 7 years ago with the Baha Tract and the like, revolutionized a fair bit of this area. However, there still remain issues with amplification and sound quality, lateral projection and cosmesis. And we kept banging on the doors of the manufacturers to invest in research and development into coming out with devices which overcame some of these issues, which would really be the holy grail of acoustic implant solutions. And they did respond, which I'm very pleased about. And that brought the arrival of the new kid on the block, which is the new Ossia implant, which the Cochlear company quietly introduced in 2018. We did not know it was coming, but we were delighted when it arrived. So we were fortunate enough to be given access to 10 of these as part of Cochlear's controlled market release. And we were the only center in the UK, among several others in Europe and worldwide. And we operated on 10 of them, mainly with conductive and mixed hearing losses as an equal distribution. Again, the sidedness, etc., were equally distributed left and right, male, female, very close by. The age distribution was mainly middle-aged. The skin thickness was average for most transcutaneous devices. However, we did have one which required skin thinning because of thicker skin. And bone polishing was taken under the actuator in some of these cases, but in the latter half of our procedures, we decided to recess the actuator to make it completely flush with the bone. We had to, because of the manufacturer's regulations, undergo strict training under the watchful eyes of our local clinical access managers. The surgery was a straightforward incision with placement of the standard Baha fixture with the implant template marked out outside, and then with the actuator placed on the fixture and then closed after the processor was tucked under the skin. And it was activated a few weeks later, and the external processor loaded. Surgery was straightforward because it uses the same Baha fixture. There's forward and backward compatibility between existing technology as well as older technology, i.e. All sorts of Cochlear's portfolio bone conduction devices. We had no major complications, no skin issues, and we were very pleased that so far there's been no device-related issues. Functional outcomes, the closure of the air-bone gap has been extremely satisfactory, in fact, more satisfactory than what the manufacturers recommended. And I've always said that's a rare event when a product does better than the manufacturer's recommendations. There's something very good about it. Usually the manufacturer would always be saying the product is better than what it actually is, but the results speak for themselves. The functional outcomes with speech reception thresholds were satisfactory. And then looking at the use of these devices, they were useful in both group and individual conversations, especially in background noise. The results were surprisingly better in the mixed hearing loss group, and which also was noticeable with the gain in high frequencies. Now, it's a known problem with many of the bone conduction devices, as you've seen in earlier talks, that the high frequency gains can be a bit compromised, especially in transcutaneous devices. However, in the Ossia, we were absolutely amazed to see the fantastic gains in the high frequency setup, which was unique for bone conduction active implants. So, having come through all the issues that I mentioned at the start, which were a heart sink at times, we've now been left with only lateral projection and cosmesis, and I'm hopeful that sooner or later the manufacturers would come up with a solution for that, and then we've got the holy grail of acoustic implants. We published our results recently in European Archives, and you're welcome to look at them. So now we are left with these two, as I've said, and we have a spectrum of hearing rehabilitation solutions. The Holy Grail was actually in the Carina implant, which Cochlear has just withdrawn for a short recently, and we had a continuum of acoustic implant solutions for hearing loss. However, now with the active implant, the gain is quite high and the thresholds are higher. We only are left with a tiny gap in between the upper thresholds of active bone conduction devices and the cochlear implantation. These are all commissioned in the UK. So if any of you have issues with local funding and reimbursement, I would encourage you to look at this document, which is a free web-based resource. The references are good on this, and you can quote this back to the funders and for reimbursement. Bone conduction and acoustic implants are still newsworthy. People get quite excited, and including very serious and dull media resources like BBC. So to conclude, active powerful Ossia implant is really bridging a big gap in the acoustic implant domain. Surgery is absolutely straightforward, and I'm told the newer versions will be even more straightforward. There are very low maintenance. There's no aftercare required because of the transcutaneous nature of the device. Wearing comfort and retention are fantastic. It's pretty aesthetic, and the processor is visible under the hair, but it's pretty discreet despite its size. The hearing performance I've told you, and backward and forward compatibility I've discussed with you as always. So evolving area, we keep encouraging the manufacturers to come up with new solutions, and I do hope this exercise with COM will drive a further race in developing better and better acoustic devices, which will dovetail with cochlear implant technology for profound hearing loss. Thank you very much.
Thanks, Dr. Ray. Just one or two quick questions there. It was a great talk. Have you seen a different willingness on the patient population to move forward with this device, given the improved cosmesis and the lack of the transcutaneous abutment? And it's probably too early to quantify the percentage which accepted this treatment in the prior generation versus the current generation. I would just be curious your early experience in that.
Yes, the ones who are looking for either conversion from the percutaneous to transcutaneous are looking for active transcutaneous devices. And the ones who were just going for transcutaneous devices, if we discuss the tract versus this, tend to favor this, although it's not been available. And many have come to us, contacting us, following some input from the current users, the 10 of them that have been done.
Sure. And then understanding this is the newer procedure and relatively straightforward and fairly quick surgery, there's always a learning curve associated with it. Are there a couple of key pearls that you've learned that have made surgery a little easier and quicker as you've had experience with this?
Yes, I think planning is the key, localizing it, because people doing bone conduction surgery or CI surgery might think it'll be a walk in the park, so not plan appropriately. And the training that the manufacturers provide is brilliant, so you know where to site it. And changing from a previous implant to the new implant would require resiting of the fixture purely because of the size of the actuator.
Great. Thank you very much. Great talk. So next up, we have Dr. Backus. He's a neurotologist, a Swedish hospital in Seattle, Washington. He specializes in treating conditions of the ear and skull base. His medical research interests focus on implantable hearing device program efficiency for improved patient access and program viability. So Dr. Backus, thank you for joining us today.
Thank you, and I hope everybody is safe and we're all dealing with COVID. And I just like to preface my talk by saying, when you're speaking and then when you put a mask on, you take all of our hearing loss patients and you put them in a whole new level of low for being able to communicate. It's been a very hot topic up in the Seattle area, since we have a very active community around hearing impairment. So what I'd like to do is really just kind of bring this home. Can I have the next slide, please? And there's been a lot discussed by the prior speakers, and I want to be very, next slide, I want to be very practical and really just be presenting some different types of cases. And one of the concepts that this study group is challenging is when you are managing chronic otitis media or cholesteatoma, there's the one side of the equation, which is managing the infection, managing the risk for recurrent or recidivistic disease, and the other side is managing the hearing loss. And as you saw from our presentation from India, where some of the chronic ears are extremely difficult to manage, my argument is for some of those patients, now that we have high resolution CT scanning, we have access to MRIs, perhaps we don't treat the cholesteatoma. Perhaps we observe the cholesteatoma and treat the hearing. Because I think Dr. Ray touched on some very important concepts in that hearing loss is hearing loss. And when you look at the risk of hearing loss and dementia, it really doesn't matter. If you're not hearing and you're still at that low level, you still get socially isolated, you still run the risk of depression, and all of the other really dangerous issues that we see. So when we look at, again, with infection and cholesteatoma, it's creating ventilation pathways and eradicating cholesteatoma or controlling cholesteatoma. The hearing restoration really depends on what is remaining. And oftentimes we upfront just tell patients that we're hoping to get a 20 to 30 decibel conductive hearing loss. And that's like, you know, being able to go to the debutante ball, but having to go with your sister. So you actually got to go, but you really didn't have a great time. We really want to bring people up to where their ears are functional. And even though we don't have good sound localization with bone conduction, we do give people awareness of the sound coming from that side. Next slide. So I'd like to walk through a series of cases. And as we're talking about those, when you get binaural hearing, you bring in the other effects that occur through the auditory system. We know that the osseointegrated devices overcome the head shadow effect. When we start talking about binaural summation and squelch effect, those are really additive at the level of the brainstem. And the initial teaching on osseointegrated devices such as BAHA is that we don't get much improvement in those two areas. And what my argument would be is, even as I see patients with BAHA who have poor sound localization in a multi-speaker room, which we test them in, a lot of them still localize sound because they're looking and they're having a multi-sensory experience. The analogy would be somebody recovering from a vestibular deficit using vision and proprioception. People are talking to someone, they hear something different, and you see them turn their head. So even though we don't have precise sound localization, clearly it helps to pick up through the head shadow effect sounds coming from other areas. I think binaural summation and squelch, I think as we dig into these deeper, we may actually see some improvements in giving people hearing from the other side, although current data does not support that. Next field, or next slide. So I'd like to just go through a couple of cases, and these are actual patients that I have treated. And there's all different varieties of using the bone anchored solution. And this is a young girl who had a congenital cholesteatoma. She's 5 years of age. You know, BAHA is been described in the US indications as 5 years and older, but what's more critically important is the thickness of the calvarium and if it can handle an osseointegrated fixture. But it's, in this particular girl, this was her pre-op audiogram with a congenital cholesteatoma in the left audiogram on the right of your screen, and she had a conductive hearing loss. And so we fit her with a BAHA soft band prior to surgery. So she was overcoming learning how to use the BAHA before she had her cholesteatoma removed. She then had her cholesteatoma removed, requiring a two-stage procedure. And that 9 months between stages, she used her BAHA soft band. When she was finally reconstructed, she did have significant enough improvement that she did not require her BAHA, but she did not lose any time in the interval with her hearing loss. Next slide. In this particular case, this is a 45-year-old gentleman who he's having progressive hearing loss and has a mixed loss. And you can see on the left side where he's had modified radical cavity created. These are the patients I think that Professor Linares was starting to touch on, where in most centers, they would be very borderline for a BAHA. We've actually taken some risk with people as the devices have become more powerful. And in this gentleman, he had a dry modified radical cavity. His presenting complaint in clinic was hearing. He needed to have improvement in hearing. He was not draining, he was not having pain. He had an MRI scan to verify there was no residual cholesteatoma. The other ear has not been operated. And we opted to place a BAHA on the left side, and actually he's doing fine. He has sought no other intervention. So this is really brings out a principle of, if you have a clean, dry cavity, you can always create a nice wet draining cavity, trying to improve the hearing by doing surgery on that cavity. And again, we look at the infection control piece. In this patient, his infection is well controlled. He has no residual or recidivistic disease. But when you look at his hearing, that is his issue. And my assumption is he most likely will pursue a BAHA on the opposite side. Next slide. In this particular case, you can see, again, a patient who has far advanced otosclerosis. If you look at the CT scan down below, you can see the cochlea in the axial view adjacent to the heads of the ossicles, and there's a ring sign around this cochlea. So we're seeing demineralization. More importantly, we're looking at a mixed hearing loss. And the traditional teaching would be to consider a stapedotomy in one of the ears to try to improve the hearing, to improve their ability to function with the hearing aid. In this particular patient, we could choose either ear. Both of them are difficult because of the sensory thresholds from their otosclerosis in both ears. Instead, we opted as a first step, not as a salvage step, to go to an osseointegrated solution in this patient in the left ear. Interestingly, it closed the ear-bone gap, and we see sensory levels that are 5 to 10 decibels improved on that left side, and they're continuing to use a hearing aid on the right currently. These are notoriously difficult cases surgically. If the patient continues to lose their hearing, we have not limited any future technological applications such as a cochlear implant, although we would pursue a cochlear implant very cautiously. One of the issues that we've found, I have a very significant skull-based practice, and when we use a Baha Attract, that is a magnet that has to be removed to get an MRI scan due to the distortion that the magnet brings into the field that we've typically operated and that we're surveilling. We've gone back almost exclusively to Baha Connect in those patients. We remove the abutment and scan the patient and replace the abutment right away in clinic when we're following their MRI scanning. We don't touch them if they're having CT scanning. What we're finding is that high frequency gain that Professor Ray talked about is much better with the Connect patients. We're only now starting to get into ossia with any kind of force. So again, thinking about what is the primary goal of your patient intervention, and if it is hearing, I think we should be looking at some of these osseointegrated solutions much more aggressively. I hear a lot, and I think Dr. Kaplan's question about, are you seeing patients more eager to get Baha now that there is a ossia solution? And to be really honest with you, I think a lot of that depends on how the surgeon and the audiologist presents Baha to the patient. I can't even think of 5 patients in the last 5 years who have told me they won't get a Baha because of the cosmetics. And I describe it as we take a little fixture through your skin, hidden in your hair, and we attach a device to that, leaving your ears open. And what's very interesting is when we look at our patients with their patient-recorded outcomes, they actually like the ability to have their ears open, and they don't mind having something behind their ear. And what I tell them is, if your goal is to hear, this is your most effective solution. Next slide. So this is a 55-year-old female who has a deep tympanic membrane atelectasis, and you can see that she has quite a conductive hearing loss on the right side. Excuse me, this is a sensorineural level that you're seeing in the red boxes. And she has a decreased speech discrimination, but when she's turned up in the audiometric booth, she actually improves to about 88%. And so she is really at that threshold that Professor Lenartz was talking about at 65 dB. And we ended up putting in a superpower on her. And she is actually a very consistent user of her Baha. She doesn't describe spectacular speech understanding on that side, but one of our biggest indications of whether a device is successful is if the patient actually wears it. And she wears her device over 8 hours each day. Next slide, please. So in conclusion, I think what we're looking for is, in the setting of chronic otitis media, are we actually breaking out, treating the infectious component, managing the disease, managing the recidivistic or recurrent cholesteatoma, and are we managing the hearing solutions in that order? I would propose that in many cases, we can best serve the patient by maintaining some of their maintenance of their cholesteatoma without surgery. and really attacking the hearing piece to improve their quality of life. I don't have very many patients tell me that their quality of life was impacted more by reducing their drainage than it was by improving their hearing. And I think with the argument made by Professor Ray throughout his talk about the issues of depression, the issues of social isolation, and the potential for preventing dementia, that is much more of a hearing loss problem. So I think if you look at surgery, the two adages I've learned about ear surgery is if I'm thinking about something new and brilliant, I need to go into the German literature from the 1960s because somebody's already probably described it. But number two, otology amongst all of the fields within otolaryngology seems to be the most nimble and the most adaptive and most open to change. And I think this is an opportunity to better serve a very difficult group of patients. So everyone's invited to Seattle. All we have to do is get past this virus, and everyone all around the world, you're in my prayers. Thank you.
Thanks, Dr. Backus. Great presentation there. One quick question that came from one of the audience members during your talk. For patient number 2 in your presentation, can you just clarify if that was an Osia or a Baha that you fitted them with?
Baha Connect.
Connect, okay, great. And one of the earlier questions that was also directed towards you before your presentation, and I figure as long as you've got the stage, you can chat. And I think your video camera is off if you're able to click on that.
I think my video camera was shut off, Dr. Kaplan, by the host. So if they could flip it back on. Yeah.
You got it. So question for you. What has been the key hurdle in providing bone conduction earlier in the treatment pathway for these patients? Awareness, patient acceptance, or reimbursement challenges?
My attitude, none of the above. I think I've always looked at controlling the infection as being much more important. When I look back at a rather large group of patients, I realized that oftentimes we never got control of the drainage as we wanted to, even using flaps, obliteration techniques. In the meantime, they weren't hearing that whole time. And when I talk to patients, it's always an uncomfortable conversation at first, but we typically then have them meet with the audiologists and do a consultation and just wear the soft band around the clinic. And that usually is a very powerful experience for them. And they're very adaptive. But I would say it's much more my attitude in being able to offer that as early technology.
I completely agree with you on that. How it's presented in those first 2 sentences often changes the entire interaction and their attitude.